All right, good morning, good morning. Welcome to your week 12 in Cancer and Infectious Diseases week. I want to record a lecture. It's not going to be a very long lecture. I'm recording this on Friday, Good Friday, Friday before Easter. And so anyway, I hope you have a great blended week this week. And let's run through this lecture. I'm going to hit some highlights. You can read a lot of the details. I don't need to go through a lot of the details and facts with you. You can read that stuff. So the PowerPoint will be helpful to you, and it'll supplement your reading, and you'll have a thread of discussion and exploratory activity this week. It'll be different, though, than what we've done. It'll be a little bit different than what we've done in the past, so I think it'll be really cool. And I think it'll facilitate really good discussion throughout this week. Can you believe we're in week 12 already? Just a few more weeks to go, and you'll be done with this spring semester. I know you'll be glad. So anyway, let's rock and roll. Cancer and infectious diseases. Let's talk about cancer. You're going to have a lot of patients with cancer. I call it an epidemic of the 20th century, now in the 21st century. And man, I don't know. I feel like it's worse than ever. And it's near and dear to my heart. I've got a niece who is just in her early 30s, and she's been struggling with breast cancer for several years now, and it's just, it's been so difficult. And you probably have loved ones who have experienced various forms of cancer, and maybe even lost some friends or family to cancer, like many of us have. So anyway, lots of different types of cancer. When I think of cancer, I think of a proliferation of cells. I feel like cells that just multiply and grow and won't go away, and they cause destruction and mayhem, and they just wreak havoc on the body, and they kill people. That's how it's probably not the most scientific way to describe it, but that's how I think of it anyway. And it doesn't discriminate. It affects all kinds of people all over the world. But you see here a list, and you can read more. It's a good link for you, different kinds of cancer. So that's good extra reading for you, and it's good details for you. But you're going to see your patients who have all kinds of these. And there are some conditions also that are precursors to cancer. Myelodysplasia is one. I lost my father-in-law to myelodysplasia, which was a blood disease. His body was just eating up his red blood cells, and he wasn't able to. He'd have to have blood. He'd have to get blood. Go into, for him, the VA, get blood, and because his body was destroying its own blood, and he dealt with that for months, and then it was a precursor to leukemia. He developed leukemia and passed away from leukemia. But anyway, so cancer, we're going to see a lot of patients with cancer and a lot of different kinds of cancer. So know the different kinds of cancer as well. Age is a risk factor. Heredity is a risk factor. There's a stat that's the second most common death in elderly. So you have intrinsic causes, you have external things that can contribute or cause cancer, environmental things as well, such as viruses can lead to cancer, chemical agents and other environmental things, alcohol, drugs, hormones. Cancer can be caused and contributed by a lot of different things. There are some risk factors, a lot of the same risk factors that other conditions have as well. So, and sometimes it's just, who knows? We don't know why someone gets cancer. So you're going to see cancer affecting people in various ways, but it's just really, for us as occupational therapists, how does it impact their ability to perform, to engage in occupations? That's how I think of it. How does it affect their occupational engagement? Fatigue is a big one, strength and endurance, of course, and maybe some structures that are involved. Maybe tumor in the brain causes cognitive problems or other types of neurological problems. So You have a patient referred to you, what kind of cancer are they diagnosed with, and where is it, how does it impact their functional performance, their safety, and all that. Their independence with ADLs, IADLs. I always start with ADLs and work my way out. That's just kind of how I think as an OT. Start with ADLs. I haven't really talked about this a whole lot, but maybe I have. And then I work my way out IADLs and other occupations as well. So, but there are some impacts on the patient, and I'm always reminding you of being mindful of not only their physical impact and their impact on their physical performance, but their impact on their psychological or psychosocial performance as well. Psychological considerations impact. Cancer treatment, we like to say that cancer treatment sometimes is almost as bad as the cancer, but cancer treatment, chemotherapy and radiation are our two big ones. And these are people, when I have a patient who has cancer, I want to know if they're undergoing chemotherapy or radiation treatment or both, and I want to know what their frequency is and the duration. The frequency is how many times a week or how many times a month they go to, they participate in their treatment. The duration is how long does it go. So frequency would be 1 time a week or 3 times a week. Duration would be for 12 weeks, right? Or however many months or whatever. So frequency and duration. And I want to know what their schedule is for their chemotherapy and their radiation, so that I can, because some of our patients are just wiped after chemo and radiation, and some of them are not as wiped, so they can participate in therapy sessions. Same thing with dialysis, which we'll talk about. But some people can participate more than others, so I want to know what their schedule is, and I want to try to schedule my visits, my sessions accordingly, depending on where I'm practicing. If you're in the hospital, inpatient rehab, you might not have any flexibility in that. But if you're doing outpatient or home health or whatever, you may be able to accommodate that person's schedule better so they can get more out of their treatment sessions, okay? So it's a good thing to be mindful of. So not only are there physical side effects of chemotherapy, but you'll notice that there's also cognitive and the psychosocial impact of hair loss and some of these other things can come from the chemotherapy, from the treatment of the cancer. So they've already got cancer, and now they've got other things going on because of the treatment. So there's a good graphic of how chemotherapy can negatively impact the various functions of the human body, okay? And radiation, same thing, similar with radiation. You're gonna have this impact. So it's gonna impact their ability to participate in therapy and participate in anything else in their life. So good to know what they're going through and how that impacts them specifically, and then you can accommodate them accordingly. This video, I wanted to include something over the years that I've incorporated in my practice, working with patients with cancer. I don't know that a lot of OTs do this. I just do it, and I wanted to share this with you. I'm always talking to them about their health, and when someone has cancer, a lot of times people can be very just unhealthy in general, and they get cancer. And it's easy to say, well, you were unhealthy, so that's why you got cancer or whatever. It's easy to say that, but a lot of times it's just not the case. But there is a way to approach, I want to approach health in my practice. So people with cancer, we talk about health and healthy eating some of the research out there suggests that cancer really thrives in an acidic environment, and it really thrives when people have a high carb diet and a high calorie, a high carb and a high sugar diet. That really creates an environment where cancer thrives. More research is needed. It's not conclusive, but I feel like it's persuasive for me. And so what I do is I teach my patients how important it is to have a low sugar diet, a low carb diet, and talk about foods that promote good health and as they're going through cancer treatment. We want them to have high levels of energy, and a high carb, high sugar diet doesn't give you high levels of energy anyway. But I would encourage you to think about diet as part of their overall health, especially in the context of being diagnosed with cancer. How can they function at their highest level, and how does diet impact that? Okay, so that's a good thing to be talking to your patients about. Sometimes patients who are going through cancer treatment will have that as part of, if they're going to the Cancer Treatment Center of America, or they're going, they might have a dietitian, they might have a physician, an oncologist who really cares about that and really is talking about that, and they might not. So talk with your patient about what cancer treatment they're going through. Are they just going to see an oncologist and they're just going for chemo? Or do they have a more holistic cancer treatment team or a program they're participating in? And is diet and other things being addressed? You as an OT can really bring that into your practice and share that with them, because sometimes just nobody else is doing that. And sometimes there is, and that's great. I put these 3 videos in here for you. They're just good, okay? The first video, for some reason, is white, not whatever that color is, that cute little fuchsia, or whatever that is. But it's a good video about OT's role with cancer, especially having to do with fatigue. That's a big problem with people who are going through cancer and chemo and radiation. They're just fatigued easily, and so this OT talks about that. The second one is a good little video about the 4 stages of cancer. I want you to know the 4 stages of cancer, and I want you to, and then there's OT's role in working with people with cancer. I like that. It's very instructive, so make sure you watch those videos. And there's another video at the end there. It's an article, Is Breast Cancer on the Rise in Young Women? And I put that article in there because I have noticed in my little part of the universe, it seemed to me, it's just in a clinical observation, living life, I kept hearing about women in their late 20s and 30s who were getting breast cancer. I'm like, what is going on? There seems to be an increased incidence of breast cancer in young women, and this article talks about that. So I just think that is it's instructive and it's fascinating. It's something maybe to research further, and as you're in research, as you move forward in research, it might be an area that you might want to delve into. So it's good. It's good. All right, so that's cancer. This is one of those lectures. This is one of those weeks where I hate being remote. I'd rather you be in here with me, and we could really this is just fantastic to discuss. It's one of my favorite classes in this course. But it's remote, so a lot of this is going to be exploring through your reading. The reading is great in your text, and you can get all of it through, most of it through that. So, all right. So infectious diseases. This is chapter 33 in your book, and you know a lot about infectious diseases already. So we're going to blaze through this. You have already been instructed on PPE and pathogens and precautions. So you know a lot of this stuff already. So you know about the direct contact aspiration into your lungs. You know, airborne pathogens can be aspirated into the lungs. Breathe in. You can ingest pathogens through what you eat and what you drink. And I also included social and structural determinants of health. And there are 5 domains that I wanted to mention here that pathogens seem to flourish more in environments that are where there is economic stability, where there's access to education and good quality education, where there's access and quality of health care, where there are neighborhoods and environments where there's just good structural soundness, where they're built and people live in neighborhoods, and social and community context affect health, and they affect disease, and pathogens seem to thrive in places with poor, these factors are just poor. So I wanted to include that, things to think about and consider when we're talking about disease and pathogens. HIV, and these are the ones we're going to talk about today briefly, but you can read more about it in your book. HIV is a big deal. I was, man, you know you're old. You know you're old when you say, I remember when such and such came out. You know, I remember, my kids think I'm ancient when I say, oh yeah, I remember when the microwave was invented. We had our first microwave. Like, oh my kids are like, how old are you? You know? But I remember when HIV and AIDS, I was a kid, and HIV wasn't, we never heard of it. It wasn't a thing. And then all of a sudden, HIV was a thing in America. And it was in the early 80s, I believe, and everyone was scared of HIV and AIDS. And at first, I remember so much fear and so much anger even, and negative and even hate, if you could call it that. You know, I hesitate to use the word hate, but yeah, because it was something that was only in the gay community for the most part, and there was such a stigma with people who had HIV and AIDS, and there was even a sentiment that those people had this because of the way they lived their lives, and they deserved it, right? So that was a thing. I remember that being a thing back then. And what a tragedy that is. And so, of course, it's not that way now, but it was back then. And it was, people were afraid, they didn't understand it, and it seemed to affect the gay community only, and so there was all kinds of things going on with it that were real negative, and fear, and there's a lot of fear about it. And then, of course, when we understood it more, and people who were not gay were getting HIV through intravenous drug use, blood transfusions, etc. You know, even children and babies were contracting it through transfusions or nursing or whatever. You know, once we began to understand it more, things changed a little bit, but it was still a lot of negative and a lot of I don't know. It was just kind of a bad deal. Rick Warren, one of my favorite preachers, one of my favorite pastors, he does a lot of ministry. He's done a lot of ministry for years with HIV, with populations in America and overseas, especially in Africa. And he calls HIV and AIDS the leprosy of modern times, modern day leprosy in America. And what he means by that is the stigma that is attached to it is much like in ancient times when people would have leprosy. They were unclean, they were shunned, they were kicked out of communities, they weren't even allowed to socialize with, it was a huge stigma with it, and they were just outcasts. And so Pastor Rick talks about how HIV and AIDS is modern day leprosy. People with HIV, back then especially in the 80s and 90s, were treated like outcasts. Very unfortunate, very unfortunate. So anyway, you in your practice will see people with HIV, and early on people would contract HIV, and then it would become AIDS, and they would die because there was no treatment. Now people live for years and years with HIV, and there's medicine for it, there's treatment for it, and they prevent it from becoming AIDS. So you will see patients that have, maybe as a secondary diagnosis or a comorbidity, we call that, of HIV. Yeah, they've had pneumonia, been hospitalized for pneumonia, but they've also had HIV for however many years or whatever. I see patients all the time with HIV. So, not all the time, that's an exaggeration, I don't know what I'm saying. I've seen quite a few patients over the years that have HIV. It's not the main diagnosis that I'm seeing them for, but it could be for sure. But so you will see this. So something to take precautions, and I would just encourage you to be patient, understanding, loving, and just treat them like anybody else. Of course, I know you will. So this is kind of like a progression of HIV into AIDS. Early on, you'll see the flu-like symptoms, 2 to 4 weeks post-infection. So it becomes, it turns into more of a chronic condition before eventually becoming AIDS. And then you'll see this immune system is weakened, it's very fragile, and they're very susceptible to all kinds of things. And they will die usually from some type of infection, pneumonia, or something secondary to that because of their weakened immune system. Different things that are, this is a slide, just another good visual about, things in the body that are affected. And there's something other in the mouth, esophagus, candidiasis. It's basically a rash that can be external and internal. It can be very horrible, just horrible, miserable. Miserable would be the word I would use to describe that. A couple of videos. Now, I just felt like these were great, and I want you to watch each of these videos. The first video is with one of my heroes. I'm a basketball guy. I grew up obsessed with basketball, and Magic Johnson, Earvin Magic Johnson, was one of my favorite basketball players of all time. Now, my favorite basketball player of all time is Dr. J, Julius Erving. I was obsessed with Julius Erving as a kid, and today he's still my favorite basketball player of all time. Played with the Philadelphia 76ers, 70s and early 80s, and he was Michael Jordan before Michael Jordan, okay? He was the OG Michael Jordan, but people don't talk about him that much today, but he was my favorite of all time. And Magic is up there. I feel like I would argue that he may be the greatest basketball player of all time. Certainly needs to be in the conversation. It makes me mad when people say, well, who's the greatest of all time, Michael Jordan or LeBron James? What, are you kidding me? What about Magic Johnson? Well, Magic Johnson, I want you to watch this video. It's an interview with Magic. And during that time early on, when everybody was kind of afraid of HIV and AIDS, and there was this huge stigma, and it was scary, and it was just bad. Something happened. Magic Johnson was diagnosed with HIV, and Magic Johnson was diagnosed with HIV not from being gay or an intravenous drug user, but from just having promiscuous sex with women, and he ended up with HIV, and it shortened his basketball career, and he was just so amazing. He was in his prime. He was so great. And something happened, though, in the public conversation. He talks about that in the video. And the public conversation changed after Magic Johnson had HIV and lived all these years with HIV, but he became a great example, role model, spokesperson. But he helped people realize that HIV isn't just for certain people, certain populations, certain behaviors, and anyway, he helped drive that conversation in a much more positive and healthy direction. So I want you to watch the video. I think it's really cool. I think it's very instructive too. But it's a good example of how something can take hold, a mindset can take hold in a nation and be very negative, but how somebody, one person or a group of people can drive the conversation in a more productive and healthy direction. And the second video is an interview with one of my guitar heroes, Brian May, Dr. Brian May, who, by the way, he has a PhD in astrophysics. Rockers aren't all stupid, okay? This guy's brilliant. They were with the band Queen, the British band Queen, one of the great bands of the 70s and 80s. And they talk about Freddie Mercury, who, very flamboyant, one of the great rock vocalists of all time, and he contracted HIV and AIDS, and they talk about what he went through. This is not long after he passed away. So I want you to watch these videos, and you'll have those in your thread of discussion. I'm going to make the thread of discussion is about this. So I thought it'd be an interesting way to go with the thread of discussion this time. But I feel like it's very instructive. It gives us insight into patients who have a condition that is often stigmatized. Often they're treated like outcasts or whatever, and we can generalize some of these principles to other conditions, other populations, other patients that we see. So. Tuberculosis. You might think that tuberculosis is a thing of the past. You have to have your TB vaccine for Complio. Well, tuberculosis is on the rise in America, believe it or not. If we don't take it seriously and keep immunizing and keep vaccinating, things come back, right? Okay, so anyway. Tuberculosis is a lung thing, it's breathing, it's infectious through airborne sputum pathogens, must be inhaled. So you will have to get a TB test every year. As long as you practice OT, you will have to get a TB skin test every year. So just get into the rhythm of testing for this, so that, because you may be working with people who have TB and have been diagnosed. You may be working with people who have TB and have not been diagnosed. So, because not everybody gets skin tests all the time, right? They're not like us. So, anyway, tuberculosis is not a thing of the past. We need to take it seriously. This is what lungs look like with TB. Good visual on that, good graphic on that. West Nile virus. The most commonly transmitted mosquito. They're ugly and they can give you West Nile virus, okay? I have no use for them. But we will see patients from time to time with West Nile virus. So they can, many of them, 1 in 5 will develop symptoms. Many of them will develop very mild symptoms or no symptoms at all. But people do die from West Nile virus. Rocky Mountain spotted fever, tick fever. We see this from time to time. And you will have patients with this. They have these symptoms. It can be fatal. And I don't know, is Oklahoma the tick capital of the world? I think it might be. I know Ohio, it may be worse, actually. Ticks are worse, and I think they're bigger, too, in Ohio. They grow bigger there. The deer and the ticks grow bigger in Ohio, okay? They just do. So Rocky Mountain spotted fever, something you might see. MRSA is something you will see. You will see patients with MRSA. So if you're in, especially in hospital settings, when I'm working with people in hospitals and nursing homes, it's tend to where I see this most. They oftentimes will develop this in the hospital or in the nursing home. Okay, so this is very common, and we have to gown up and glove up and everything. So it really makes them weak. especially makes them weak, and it can really, I've had patients that have been really, they're rocking along, they're really making progress, and maybe even they're talking about going home, and they'll develop MRSA, and it'll knock them back, and make them weak, and it'll really hurt them. And C. diff, which we're going to talk about too, is another one that can really weaken their recovery. So you're going to see a lot of people with MRSA. Here's some pictures. I know I didn't prepare you. Here are some pictures in there. Did I have? Oh yeah, in the previous slide here. If you want to see more photos, that's a good website to go to. There's photos there of people with MRSA, but there's just a few cool ones that I wanted to show you, the people with MRSA. Hepatitis, so be reading through your hepatitis, know the symptoms, hepatitis A, hepatitis B, hepatitis C. I've included a great website. CDC has a really good, that's a really good website anyway, but this talks about the various types of hepatitis, kind of walks you through, gives you some really good information. I know you don't read enough. You're always complaining about not having enough to read, so I included that for you. You're welcome. All right. So hepatitis B, transmitted through sex with infected partner, infected needle. You have to have the HB vaccine for field work. Hepatitis C, I think of hepatitis C, I think of the liver, and I think of alcoholism and IV drug use, and usually it oftentimes develops into chronic liver disease or even cirrhosis of the liver. Here's a good visual of cirrhosis of the liver. Healthy liver versus a cirrhotic liver. C. diff, you're going to see C. diff. It's nasty, okay? When I think of C. diff, I think of diarrhea, okay? It's nasty, it makes people weak, and it will set people back, and it does kill people if they've got other conditions. You're working with people who are already compromised, who already have whatever they have, and they contract C. diff. It can really knock them down. It can really hurt them, and some never recover if they have really compromised immune systems, or there's other infections they're fighting. Sometimes I've seen it be the death knell of some of patients over the years. So take your precautions. Here's a little slide on shingles. Shingles is kind of a mystery to me. It's the virus that causes chickenpox, causes shingles. You just kind of carry that, and a lot of times I've read that stress will bring it on. I don't know why. Sometimes we just don't know why it'll just manifest. I remember I organized and led a mission trip to Puerto Rico. I think my son Reese, he's 19 now. I think he was 8 or 9 or something like that. And we went to Puerto Rico, and one of my friends, who's an old coach, retired coach, football coach, he's a hoss. He's a worker. He's a big, strong, tough old boy, and awesome guy. And he and his wife went with us. She's a retired teacher, and we went to Puerto Rico. And like the first day we were there, he contracted shingles, or he started manifesting shingles, and he was in pain and miserable the entire time we were in Puerto Rico. And he didn't get to do hardly anything. The last day the last 2 days he started feeling better, and the last day he was able to get around better. And then we went home. So he missed out on that trip. It was miserable for him. So I don't know. It's just sometimes stress, some stressful event might bring it on. But anyway, there's a rash. There's a blister phase often. We take contact precautions for it. There's some pictures of shingles. You probably know people, maybe you've had shingles, maybe you know people that have had shingles. They are miserable. Lupus. Primarily affects women, 20 to 40 years old. I don't know why it's picking on women, but it does. So you may think that it's caused by hormones, estrogen, genetics, maybe ultraviolet light exposure. I don't know. always getting on to women for laying in the sun or going to tanning beds, you know, but I can't stop Mrs. Wengert from doing it. She loves the vitamin D and she loves to have dark skin, and I like it, so whatever. Skin rash, joint inflammation, and all that. So you go to a rheumatologist for this. A great website, Cleveland Clinic. There's good information on lupus. And here's a picture of a lady with this butterfly rash who has lupus. So you might see people with lupus. All right, so on in chapter 33, there's a great table in there that has infectious diseases and the precautions that we take with those. I want you to be reading through those and know the precautions that you'll need to take through those. I don't have to walk through that. You can read better than I can. So, and then the last slide is the references. Okay, so you'll notice I'm in a different classroom today. Got the big screen, so this is kind of fun. All right, so this is your video lecture. I'm looking forward to seeing your posts on your thread of discussion. So be looking at the instructions on that, and holler at me, call me, text me, email me, whatever, if you need me for anything else. Have a blessed week, and I hope you had a great Easter, and I hope you have a blessed week this week. All right, love you, bye.